Hello, the case I chose is an insulin overdose, which is a case presented by AHRQ. The case itself is the story of a 78-year-old male who was admitted for acute myocardial infarction. On admission, his abdomen was noted to be distended and rigid. Although on several ionotropes the vital signs were deemed stable. Laboratory findings indicated progressively worsening kidney disease. The surgical team suspected ischemic bowel, and the plan was immediate surgical intervention. Little background on this is the senior anesthesia resident had been on call at a large hospital for more than 20.5 hours. The case itself presented around 3 o'clock in the morning, just after the senior anesthesia resident had finished a long surgery, and now he is being called out to the bedside of this patient. The team was made up of the attending physician, the chief resident, and other anesthesia residents. Once the patient was taken into surgery, the diagnosis of ischemic bowel had been confirmed. The patient was also to receive blood products due to volume loss during surgery. Laboratory tests drawn during the surgery indicated high potassium and high creatinine levels. The attending physician wanted to address the high potassium and gave the order to the chief anesthesia resident to give 10 units of insulin, in addition to other potassium-lowering treatments. The resident anesthesiologist drew 10 cc's from an insulin vial and administered intravenously. The error was immediately recognized, and the attending and chief resident were notified. The patient received supported IV glucose with no hypoglycemic episodes. However, the patient expired a day later due to a disease process. A root cause analysis was conducted to find the cause for this error. The root cause analysis went into 5 different categories: human factors, communication factors, equipment factors, environmental, and education training factors. The first factor was human factors. Long hours of work, the 20.5 hours the resident had been on duty, were deemed to be part of the problem, part of the cause. Another contributing factor was the hierarchy as a human factor. The residents did not feel comfortable questioning the attending physician in front of other residents and his order. That led to fear to speak up. On communication factors, there was no verbal order. The verbal order, there was no readback. The order was never written down, so it was not clarified either. And also, as part of the communication factors were the assumptions of treatment. The attending physician assumed the residents knew how to treat hyperkalemia. Equipment factors, several syringes were available, 10 cc's, and also insulin syringes. However, the resident was not comfortable or did not know which insulin is used for insulin. Another equipment factor was the insulin having a high concentration, which was not diluted. Environmental factors, it was an emergent surgery, there were too many people in the room, and in a fast-paced environment in which life or death happens, errors are prone to happen if the factors are not controlled. Education and training, the residents should have had hyperkalemia treatment education, how to deal with it, and also how to use the equipment to deal with hyperkalemia. They should know the difference between a 10 cc syringe and an insulin syringe. And communication training. That's another part that was deemed to be a root cause analysis. The patient mistakenly received 1,000 units of insulin when the resident was verbally instructed to give a surgical patient 10 units during emergency surgery and utilize a 10 cc syringe to draw from a concentrated insulin vial. According to AHRQ, administration errors account for 26% of all insulin-related errors. Ordering, which was the verbal ordering in this case, account for 49% of errors. The action plan, communication training, teamwork training, address the concentrated insulin preparation, perhaps have it readily available as a diluted solution, equipment training, training the residents on both insulin syringes and the 10cc syringes and which one is used for what. Also, address the medical treatment protocols for hyperkalemic patients. And the last one, which is a little more complicated, is evaluating the length of resident shifts. Barriers to action, the hierarchy. The ability of the residents to feel comfortable to question attending is a true barrier that exists. The residency structure is another barrier to the action plan. Residents will continue working extended shifts where fatigue and multiple patients will and possibly will get in the way of safe care and delivery. Thank you.